physios, what is our primary aim being a sports physio? Anyone? Anything else? No, nothing from this science. I think they're hungry. Anything? What's our primary goal as a physio? Prevention, okay? Because we don't want to wait till the injury occurs and then we start working on it. It's like, oh shit, now what do we do, okay? So how about what we saw in the previous presentations was a bit of statistics, a bit of research based on everything. So me being a clinical physio, I come from a very clinical background of over 14 years and 5 World Cups later, I think I have started to understand a bit, and what I really like to do is sit with our SNC coach and discuss it, because we are a team together and together we bring out the performance in the athletes, and our aim is to prevent injuries. So how do we do that? So little at the end of last year we started doing something, we never named it, we started assessing our athletes on daily basis. And as we all know, pacers are at a high risk of sustaining injuries, soft tissue injuries as well as bone injuries and other injuries. We thought, why don't we just give them a quick look every day, see what the patterns are, and maybe I can talk to my SNC coach, boss, this player is a little stiff in the hip, can we work a little bit more around the hip in the priming sessions, in the warm-up, so that they are at their optimal when they actually take to the ground. Isn't that more practical? Like, we are going to talk about practical stuff in this next 17 minutes. So, we all know what is limb length inequality, right? But when we are dealing with cricket specific, we know it is unilaterally dominant sport, okay? And the beauty of it is now with the evolving T20 cricket, the shorter format is going to be more and more intense. So what do we see when we do our assessments, right? Okay, so when we talk of functional limb length inequality, it's actually a non-osseous shortening, okay? The leg is not actually short, but it appears short. And why does it appear short? And when it appears short, maybe we can see a limp in the athlete, which is not actually a limp, it is just unequal distribution of weight. Do you all agree to this? Have you all seen it? Yes, great. So it's basically asymmetry of the lower extremity without a concomitant shortening of the osseous components. So what could be the contributing factors to this limb length inequality? Any ideas? QL tightness. Anything else? Psoas. Anything else? Sorry? Hip ER. Okay. Pelvic rotations. Great. That's nice. Okay. So, would you say that the second picture, the person has a limb length inequality? Yes? When we look at it, oh, there's a leg shortening. And when we talk about this in front of the player will think, nahi yaar, mera ek pair chota hai. One leg is smaller or shorter. No, that doesn't happen like that. Sometimes these are adaptations of the athletes. And when we see the culture of cricket in India, most kids start playing cricket at the age of 3 or 4 in their house, in their neighborhood, with their friends. So do you think when they start playing cricket at say 8 or 9 years, go through puberty, keep playing cricket, and the skill that they are acquiring, do you think there are going to be adaptations in the bones as well? Right? Bones, soft tissues, cartilage, everything. So are we looking at something that has been, that we see as a result of adaptations over these last few years? Right? And just because we see it here doesn't mean it's wrong or there is something wrong with the player. We do not need to put players in, in equal. They need not be symmetrical, because these adaptations may be helping the athletes perform their skill. Okay? So when we look at functional limb length, what we did is we took 70 athletes who had taken part in the national camps. Okay? So the testing that was done on them was uniform, and we have seen the trends in what results we saw, okay? And we would definitely encourage more and more physios doing it, SNCs doing it, so we have a good data, like we have qualitative data. Right now this was in the first stage. Okay. What we saw, okay, we all know what is lead leg and trail leg, yes, no? Anybody who doesn't know? I'll be happy to talk about it, okay? So bowling arm is the trail, because it's the legs goes behind, okay? The non-bowling arm is the one, the non-bowling leg side is the one that goes into contact. So this we always consider as the lead side, okay? That is what happens when we talk about pacers, okay? This will give you a better perspective of why and how we see the kind of observations we've seen in the MSK screening, okay? So we always see a longer lead leg, okay? What really happens on the front foot contact? Okay, this is the front foot contact. It's always a bigger stride, right? We've seen longer lead leg in majority of the players. So out of those 70 players that we saw, 69% of the pacers, the lead leg appeared longer. 59% of the spinners it appeared longer, and 64% of the batters. Okay. Next, we did Thomas test. We all know what is a Thomas test, right? Knee to chest on the edge of the bed. So we did Thomas test and we observed tighter hip flexors on the lead leg as compared to the other. We saw there was more abduction of the hip again on the lead leg. Okay, this is a consistent pattern we saw. And then we also saw reduced hip internal rotation again on the lead leg. Can we all try and correlate that with the pace bowling action? Can we all do that? But we can also correlate that with batting. Now with more aggressive form of cricket, aggressive batting coming up, do you think there are more cross-body rotational shots, cut pulls that are being played more, sweeps that have been played more, right? So maybe we see that in batsmen for that same reason. We do not know at this point of time, but this is just an observation we saw, right? Next. Again, lead leg, 90%, trail leg. Okay, so when we talk of lead and trail, so this is all skill sets, okay? So highest we saw lead leg appear longer in pacers. Highest amount of trail leg, of course we can't have everybody sitting in the same thing. There are going to be atypical cases. So we did see the opposite side, the bowling side, the lead side being longer in just about 30% of the players, okay? And neutral, more or less equal in about 17%. Interesting statistics. Okay. So what really happens in this position? Can we all agree that there is anterior rotation of the hip on the lead leg? This is, sorry, what is, yeah. So when you see lead, his left leg is lead leg. There is anterior rotation of the hip. There is external rotation of the femur, okay? It appears that there is external rotation. Then on the other side, on the trail side, there is posterior rotation, because when you look at pace bowling, it's a completely rotational work, but at the same time there is a lot of forces that are directed forward, horizontally forward, okay? So what we saw when we did our assessment included, some of the tests that we did was assessing functional limb length inequality, assessing hip internal rotation, ranges, and a Thomas test, which included 4 more things: your hip flexors, your adductors, rotation of the hip, and the hamstring, okay? So what we saw is hip flexors were tight on the lead side, hip internal rotation deficit was there. Just like how we have shoulder IR deficit, we all know that, right? Similarly, there's a hip rotation, internal rotation deficit also. So we saw rotation deficit on the front, shorter trail leg, tight hip adductors, and a longer front leg. Pretty interesting. So what does that really mean? You know what hip internal rotation deficit is, right? Just like reduce range of internal rotation to gain external rotation. We saw a lot of athletes having reduced internal rotation of the hip. That means their adductors were tight and abductors or hip external rotators were slightly tighter and shorter, and the internal rotators, okay, or the adductors were probably slightly weaker. Okay. Hip IR deficits. Lead leg, again 67% of the athletes had hip internal rotation deficit, and again if you see, majority of those were in pacers and trail spinners. Okay. So I think we have already discussed the biomechanical demands of pace bowling. Do you want to go through it again, or I can skip it to the next one? We can skip it? Yes? Anybody said no? Okay, we'll skip it. So basically anterior, should I not? Okay, so what happens is the pelvis has to, on the lead leg, the pelvis has to rotate, okay? In pace bowling, it has to rotate towards the non-bowling side. So what happens with repetitive rotation, okay? The pelvis rotates on an externally rotated femur. So usually the leg lands in slight amount of external rotation, and then for further during the front foot contact, and then when they go through follow through, there is more rotation at the hip, okay. So it keeps jamming, leads to limited hip internal rotation, okay. Tighter hip external rotators lead to limitation of hip internal rotation. Again, now there is anterior tilt of the pelvis, okay, on the lead side because the way they land, and tight hip flexors. So what happens is when there is an anterior tilt of the pelvis, is your hamstring length going to be like a resting length is going to be slightly longer, the attachment has moved up. So have you ever observed your pacers complaining of stiffness of the hamstring on the front side? Yes, lot of them may or may not correlate with back pain, or they may or may not have a history with back pain, but it is something to think about, right? Now the resting length of hamstring is increased. Does that also mean there is higher eccentric forces that are required for that control of the movement, right? So higher eccentric loads on an already lengthened hamstring leads to higher risk of an injury, okay, in pacers. So this is where we speak to our SNC coaches and ask them what would they do to offset this, not to change the position of pelvis, but to make the hamstring eccentrically stronger, or to an extent stronger where it can take that eccentric load. Okay, so now we saw there is a very tiny muscle. You know what this muscle is? Sorry? Obturator which? Internus, externus? Internus, okay. So this is a very tiny muscle, okay, that has been found to be tight and contributing factor apart from other hip abductors and external rotators to be one of the leading reasons why there is limited internal rotation. Okay. So we don't only look at the glute med and piriformis and all those muscles, we do have to look at other muscles that can be contributing. So this small guy has been pretty notorious, and that is something that we realized what was happening. So if you see, this muscle is actually externally rotating the hip, okay, the femur. So every time there is a forced rotation, do you think this muscle will be finally tired and say, okay, fine, I'm tight, I can't do things, right? Okay. Demand analysis. This is the reason why we see longer front leg. You see his front leg is stretched forward. Pelvis rotates. Now the back foot. His right is the back foot. If you see there is hip extension already at his back foot. Okay. His right is his back foot. Hip rotation, hip extension is already happening. So what does that mean? Your rectus femoris, the resting length is now going to be slightly longer, more eccentric workloads on the rectus femoris, higher risk of quadriceps injury on the front foot, back foot. Front foot, who said front foot? I think you are hungry. Okay. Front foot is the non-bowling side, back foot is the bowling side. Okay. So here we have seen a pattern of quadriceps strains, quadriceps niggles more on the bowling side, which is the trail leg, and we've seen a pattern of hamstring niggles and injuries on the front leg, which is the non-bowling side. This explains it. Okay. Higher eccentric strength of the rectus femoris is required to reduce the impact of the biomechanical adaptations that are taking place. So we already discussed this. Why do you think that there can be a functional limb length inequality? It is not discrepancy, it's inequality, and it's functional because of the anterior tilt of the lead side. Okay, they keep moving, they keep moving. Next time when you are with your athletes and when you are with your pacers, just do it. Just get them into a Thomas test position and see what you find. It'll be game changing for all of you, and it probably can give us some more insights. So tilting of the pelvis, tightness of the small hip, external rotators of the lead leg, and sacral rotation towards the trail side, towards the shorter side, which appears short but is actually not short. It appears short. Batters. So we can't be biased only towards pacers just because they are at a high risk of getting injured. Our batters are equally important. So when we look at batters, possible we don't know if it's because of now the more number of cross rotational shots they might be playing. Maybe if we would have done the same study few years back or during test cricket, where the choice of shots that they are playing might differ and might also reflect in what we find in our assessments, who knows. So yes, we do see very similar patterns in batters and in spinners, but much lesser, because in spinning they don't really go into lot of forced flexion at the hip and spine, but it's more to do with rotation. So obviously we have seen hip internal rotation deficits in spinners. So what can happen if we don't address functional limb length inequality? I'm not saying that we should bring them equal, but if a little bit of mobilization can help them get better range of motion at the hip and reduce any pathologic counter rotations or the load on the spine, then I think we've done our job, right? So if we do not look into the functional limb length inequality, we just let it continue to increase, the lumbar spine has to compensate for it, because our body is just like a cricket team, right? There are top order batsmen, your glutes are your top order batsmen, right? Because if the glutes fail, who has to take the load? Your back and your knees and everything. So you need each and every part of the team. It can affect your lumbar spine. There is good association of bursa inflammation. Hip impingements have been seen, not in cricketers but in a different sport. SIJ dysfunctions have been seen. Lateral knee pain and osteoarthritis have been reported in other studies. Simple, how do we assess it? As physios, as on-field physios, we need something that we can do with investing minimal time, has to be practical and has to be most importantly actionable. We have found something, but if we don't action on it, it's no use, right? So there are many ways in which how we can assess limb length inequality. Of course, we can get a scanogram, we can use the traditional tape method and this Basto method, which was nice. But what we have done is we have modified it a little bit for our assessment, and our IPS, injury prevention screening, takes as less as 3 minutes for the entire assessment and another maybe 2 or 3 minutes to action it. So we are essentially spending 5 minutes per player and trying our best to get good range of motion and reduce the risk factors. We are not completely removing them, but we are helping our athletes get better and achieve their optimum. So why we are choosing this particular assessment method is because it is easily administered. You do not need a physio bed, you do not need anything. You can just get the player on the ground and assess the athlete. I'll get back to you about how we do the assessments. It does not require any equipment, no tape, nothing is required. It does not require high level of expertise that only a physio can do or only someone can do. If you learn it well, if you are able to practice it quite often on a lot of players, it's just very easy. It's very quick, few seconds. Variations can be tracked. So now when we see our pacers, we can actually track variations depending on their workload and what kind of matches they have played. Has it increased, has it decreased, or are my interventions helping to maintain it? If the athlete has other niggles that associate with limb length inequality, we know where the actionables are. So what can be how do we assess it? the athlete is on the floor or on the physio table in a bridge position. They bridge twice, okay, to square the pelvis, and they actively extend the feet. So the physio is not influencing or pulling their legs anywhere. The athlete is just extending the legs and the physio just looks at the malleolar position. Okay? We can have a look at the malleolar position from the top to assess which leg appears longer or shorter. Right? Easy, doable. I think I've bothered a lot of physios in the domestics for this. What are the live interventions that we can do? So once we assess limb length inequality or hip internal rotation, which takes another 20 seconds, and a quick Thomas test, what can we do? We can just mobilize the hip a little bit. As physios, we use our Mulligan belt. We can talk to our SNC coaches, can we have a little bit more hip mobility or internal rotation specific drills for this athlete? They can go for a soft tissue massage. You can do your muscle energy technique specific active mobility drills in association with the SNC coaches. Activity modifications of what exercises might increase it or decrease it or can help it just for a day or two, and we can keep a track on how things are happening. So always for me, physios and trainers and SNC coaches, our skills coaches, and most importantly the athlete, they together form a team, and together only we can prevent injuries, right? I think these are the references, and I won't eat up in your lunch time. Thank you very much.